So today we're going to talk about CHF, congestive heart failure. And let's just take a step back. Anytime you get a question on any board exam or see any patient, the first thing I want to do is read the question correctly and decide if, are they asking me about the acute management of the disease, what I'm going to do right now, or are they going to be talking about the chronic management? And one way you can figure it out, where is the patient? Are we in the emergency department? Probably about the acute therapy for CHF. Or are we in this nice, relaxed setting on a telemedicine visit talking about the chronic management? So what is the key thing is that anytime there is the chronic management of any disease, there's my favorite M word. What is that? Mortality. What are things I could do to make the patient live longer, improve survival? And when we talk about congestive heart failure, there are two broad categories, the drugs and devices. And today, I'm going to be talking about the drugs that have mortality benefit when we talk about chronic CHF. So what's number one that jumps to mind? It's got to be the beta blocker. And I know, and you know, there are certain beta blockers that have the best data in the whole world. Everyone wants to be on carvedilol, known as Coreg and metoprolol, of course, but sometimes insurance kicks in and you get what you can get, and your patient's made up on atenolol. Other categories that do it are ACE inhibitors. And yes, I wish everyone could afford Altase and Ramipril, but you get what you get. You may just end up being on lisinopril, and definitely ACE inhibitors will improve mortality. If you can't tolerate an ACE inhibitor because you're getting angioedema or you're getting that bradykinin-induced cough, well, ARBs definitely have some data. Angiotensin receptor blockers about reducing mortality. Things like candesartan, that one just jumps to my mind. And then of course, some of the other drugs I'm going to mention really depend upon your New York Heart classification, meaning that are you a class 2 or 3 or God forbid class 4. But I want to mention a drug called Spironolactone. And there's a classic RAILS trial that showed that, in certain individuals, it will actually reduce mortality. And there's a brother of spironolactone called eplerenone, and it reduces mortality in CHF in those who actually are post-MI and have a low ejection fraction. And the name of that trial is the Ephesus trial. I can't believe I remembered that. But when we talk about chronic CHF, race does matter, meaning that there are studies that show that in individuals who are African American, the combination of hydralazine and a long-acting nitrate may actually reduce what? Mortality. So please remember that. Now, there are a couple of other drugs out there, and I think everyone was waiting for me to say this. There's a drug brand name called Entresto, and that's a hot topic on the board exams. So what is the generic name for this? It's Sacubitril. I do hate these names. You do know that, right? And Sacubitril is actually called a acetylcholine inhibitor. So everyone's going to ask me, well, how does Sacubitril work and what is an acetylcholine inhibitor? So there is a hormone, and that hormone is called ANP, atrial natriuretic peptide. And what does it do? It kind of works the opposite of aldosterone. So aldosterone makes you want to retain sodium. Trust me, you don't want to do that in chronic CHF. ANP makes you dump it out in the urine. And where sodium goes, who follows? Of course, water. I saw you say water. I'm so proud of you. My camera person said water. So anyways, and that's what you want in CHF, is to get rid of all the water, and so what happens is who actually will break down, this enzyme is acetylcholine, and that's going to stop ANP from doing its job. So what do? We inhibit it. So an acetylcholine inhibitor is Sacubitril, and that's why we use it. But what happens, Entresto is two drugs put together. It's combined with an ARB. Which one? Valsartan. And why do we do that is because when you are using an acetylcholine inhibitor, you get a reflex increase in angiotensin II, and you don't want that, so we block it. And the last category of drug, brand new, that actually will reduce mortality in CHF, works on the heart rate. And when you have heart failure, you definitely want to have a well-controlled heart rate. And of course, what is the best category of drug to use for heart failure? Beta blockers. You got to use the beta blockers. But remember, no beta blockers in the acute exacerbation, only in the chronic management. But if you can't achieve the heart rate with only a beta blocker, Well, there's a drug called Ivabradine. And how does Ivabradine work? Well, it actually works on something called sodium funny channels. Now, I gotta tell you something. These channels, they're not funny at all. But that's where they work on. And you actually got approval if you can't get the heart rate at your target using a beta blocker alone. Those are the drugs that reduce mortality in CHF. No, please note, there was no digitalis, there was no calcium channel blockers, because they don't reduce what? Mortality. They don't. And if you want to get more pearls, you know what I'm going to say, read my mind. Go check out my website. It's beyondthepearls.net. We have this amazing quiz for the USMLE to see what type of test taker are you. If you want to find out what study type you might be, you know what? Take that quiz. Find out. I'm telling you, it's going to help you out, organize your thought process, and eventually get the score you want on your board exams. I hope you enjoyed today's Pearl.